Dr. Dennis Patterson here again. I'm once again by my trusty sidekick, Melissa Delamora, one of my advanced practitioners here at Nevada Advanced Pain Specialists. God, we all the time see patients who have spinal issues that get referred to us for an epidural. I guess in your mind, what is an epidural, or what kind of patient are we doing it for?
So in my mind, an epidural patient would be somebody who has neck or back pain with an extremity pain. So we're trying to calm down something in the spinal canal that is pinching off and causing nerve damage. And
I describe that to patients all the time. A lot of times when I do an epidural, somebody comes in and they just got axial neck or lower back pain. Could an epidural help them? Yeah, but typically, epidurals are meant more for radicular pain. And radicular pain is where a patient has some type of anatomical anomaly in their spine, either a herniated disc or a degenerative neural foramen that's pinching the nerve that goes down their arm or their leg. When you're seeing a patient and they're going to have an epidural done, how would you describe the procedure to them?
So an epidural procedure is actually fairly simple. The patient gets numbed up at the area of injection. They have a poke and a sting, and then they have basically a shot of steroid into that area. They may feel a little discomfort just very briefly, and then the injection's over.
Okay. And where do we do these procedures? Is it something we do here in the office, or?
Yeah, we usually see patients in the office for them. They're pretty simple. It doesn't require a facility or surgical suite or anything like that. It's something that we do here.
Yeah. It's a procedure that's usually booked for a 15-minute appointment in the office. Usually patients show up right up when the procedure is supposed to be done. We take them back into one of our procedure suites. We lay the patient down on the table in a comfortable position, and then you're exactly right. For safety reasons, we'll use an X-ray to show us the level of interest that we're looking at to treat. And just like all of the procedures we do, we then clean off their back with some sterile soap and use a sterile drape to cover up the area to work. And I think how you described it is perfect. When you numb them up, it's a small poke, kind of a stinging sensation, and then numbing medication, when you numb it down, it just kind of burns. But after that, after the patient's numb, there's really not much discomfort. Through that numb tract of tissue I've created, then I put a needle down into what's called the epidural space, and it's the posterior part of the spinal canal. And once I get there, I inject three things essentially. One, I'm injecting contrast. Contrast just confirms I'm in the right spot. It's a safety check for the patient. Second thing I do is I put numbing medication. Numbing medication, is diagnostic, plus will make the patient feel good that day. So they'll walk out with less pain than what they came in with. And then lastly, I'm injecting that steroid. And I always just try to describe what the steroid's doing for patients. And what I tell them, it's like a potent anti-inflammatory. It's like taking an ibuprofen, but instead of taking it and it going throughout your entire body, I'm putting that ibuprofen in the entire dose exactly where that problem is. The second thing that it does is that steroids cause atrophy of soft tissues. And so when I put that steroid in that area, usually you're right, there's some type of disc, ligament, or maybe even a facet capsule that's pushing on or irritating that nerve. And those are all soft tissue structures. And if I can get those to shrink down and stop pinching or rubbing up against that nerve, then I can get their pain to go away long term. And that whole process of doing that procedure literally takes sometimes 30 seconds, sometimes it takes 2 minutes. It's so straightforward. I think a lot of patients are surprised in how fast and easy it is.
Correct. I think the most important thing for patients to know for epidurals is that steroid, the day of the epidural, they're going to feel great because that numbing medicine's in there, so it's probably going to be the first relief they've had for a while. But then after that numbing medicine wears off that day, the steroid can take up to 2 full weeks to fully kick in. So sometimes they kind of go back to baseline, but that steroid just needs to work in there. And then we kind of judge how well it does at about the 2-week mark.
I've seen patients where it helps for a couple days. I see others that helps for a couple weeks. I see others that helps for months to years. And I've seen some that I've done one injection and I've never seen them back because they were cured of their problem. As far as complications and following the procedure, what do you tell the patient could potentially happen from having the procedure done?
So the potential complications from an epidural would be in that canal. It can be a dangerous and scary place. That's why we use running X-ray and contrast so that you're in the right spot. Knock on wood, we've never had anything like that happen, but it's a risk that they need to be aware of.
Correct. Anytime you poke a needle through the skin, there's risk of infection. I don't think to my 10, 11-year career I've ever seen an infection from an epidural. Have you?
No.
2, you worry about bleeding, because it's a confined space, you're right. And if you poke a needle in there and they bleed, the blood has no place to go. Then that could act as a compressive force and can push on the nerves and cause paralysis. I've never seen that complication that we've been working together over my career. But we're very diligent about making sure that patients aren't on oral anti-inflammatories or anticoagulants that cause bleeding. And if they are, then we're going to make sure they're going to stop them appropriately so we can do the procedure safely.
I think the other thing to remember too with an epidural is if you've had an epidural before, it doesn't mean that you're not going to benefit from another epidural. Maybe in the same spot that we would get records and look at things, but I've had patients maybe had an epidural in the neck and then they come for the low back, and every time we give a steroid injection, it's a different result. So we just kind of have to judge it at that time.
And you're exactly right. That brings up a good point. There's different types of epidurals, and one's called an interlaminar epidural, another one's called a transforaminal, and another one's a caudal epidural. And it's amazing how patients can have a different response by changing what type of epidural you do.